We have to establish a new route for the absorption of fluid. We actually have to create a drainage system.
Physicians have to know that trabectome surgery is a very safe and very effective procedure that can deliver results that are very similar to trabeculectomy, but are safer to achieve, the surgery is shorter, and at the same time, better vision, which is so important for patients, can be delivered.
Especially, if there is a particular group of patients that trabectome works so well that it's almost, I feel like you have to do it for the patient because these patients suffer. My mother had glaucoma, It was so hard to give her the medication. It would burn her eyes and, she wouldn't put it in. So every morning and every night I would go and put the medicine in. And she would kind of, with her eyes, she would say, it really hurts. I said, Mom, we have to do it. Right. It hurts them. Right. And, if we can do something so that they don't have to, especially older patients, right. don't have, and they are going through a cataract surgery anyway, these patients can really benefit. At least the knowledge. Anything is fine, but to have the basic knowledge, right. Yes, at least choices.
But then we look at glaucoma and we see that the trabeculectomy was developed in 1960. It's been like 50 years or so of time has gone past where nothing really new has come up.
Long-standing evidence from pediatric glaucoma that if you incise this tissue in babies that have glaucoma, if they're born with it or develop it shortly after birth, you can reestablish outflow. So the concept that if you remove the meshwork or cut holes in it or slice into it, improves outflow is a long-standing, goes way back. George's idea was to use a bipolar cautery, a miniaturized instrument that would vaporize this tissue. It really led to the development of the trabectome. The instrument includes in its business end a bipolar cautery that generates an arc like a lightning bolt between these two poles in the instrument, in the center of which the heat is extreme, perhaps like a lightning bolt, thousands of degrees. What this accomplishes as you feed tissue into this, when you're rotating this through the angle, is it creates a plasma, so-called. It literally ablates or vaporizes the tissue. And this is associated with an inflow of fluid from a bottle that's hung up outside the eye, and then aspiration through the center of the instrument. So as you ablate, create this plasma of disintegrated material, it's aspirated and taken out of the eye. The advantage of that compared to just cutting is that you remove a lot of inflammatory stimuli. If you just cut through the tissue, for example, like in pediatric cases with goniotomy, where you slice through the meshwork, the shards left just fall back together and seal up in most cases. But with the trabectome, you're actually removing a strip of tissue which theoretically leaves an opening that is much more persistent.
Trabectome has, to me, I'm excited about it because now you've got very few complications, very good results. Finally, what convinced me, though, is I know Dr. Peter Netland, he just got a new trabectome there. After he used that, he called me back up and told me his results, and he said that it was very favorable. It's a good technology and it's good for patients.
We do a lot of glaucoma work. Actually, one day in my practice, I was counseling a patient on having trabeculectomy surgery, and they said, "Doctor, what about this trabectome surgery?" And I said, "Trabectome, yes, I've heard of it. I don't have much experience. I've never seen it performed before. But I'll investigate it, and it may be an option for you." I thought, it's really good to listen to your patients because they can open your eyes a lot. It made sense that if we can de-roof Schlemm's canal and reopen the drainage canal from the inside, that if we had direct access to the venous plexus system that drains aqueous away, then this might work, and it might reinflate Schlemm's canal, which is usually quite dry in a glaucoma patient because of the primary obstruction within the trabecular meshwork. I read up on it and said, you know, this procedure actually looks like it can work.
You know, my idea of the ideal trabectome patient is actually expanding, and it continues to expand. You know, I used to think it was initially just people with mild glaucoma that needed a modest reduction in their intraocular pressure. And then as I became comfortable and as I started to see nice results, I expanded it to mild and moderate glaucoma with little tweaks that I performed in my technique, both intraoperatively as well as the postoperative management. I was able to continue to get really good results, and even great results, to the point where I've now expanded my indications to even include some patients with advanced glaucoma. And at this point, I am very comfortable performing trabectome even on patients who need intraocular pressures as low as 12. Almost all comers, with the exception of chronic angle closure glaucoma or certainly neovascular glaucoma, which is a type of angle closure. I'm also not a big fan of performing it on patients with uveitis, active uveitis. But as long as the eye is quiet, I think it's reasonable to do.
The burden of the medications on patients is more than what we really see. We can say, oh, you're on 1 drop, oh, we have to add another drop, oh, you're on 3, just keep up with your drops and I'll see you in so many months. But the in-between of what happens to the patient on that level of the patient experience is a whole lot more than we really, I think, realize. From the irritation in the eyes, from the worrying about putting the drop in, to if they go on a trip and they miss it, wondering if they're going to go blind in those few days that they're away from their medications, all that worry, all that stress, all those things, like I said, this opportunity to be able to provide this to my patients allows me to give them hope that there are other options. And again, knowledge is power.